So now we will be starting with our next panel discussion on airborne infection control. And the question that we are discussing today is, are there any magic bullets? So first I would like to invite our panelists, Dr. Atul Mohan Kochhar for NABH. Not there. So Dr. Sanjeev K. Singh from Amrita. There. So Dr. Sarabjit Chadha from Fine. Please, sir, if you could come and take your seat. And Dr. Malik M. Parmar. So we would also request Dr. Upasana to please join the panel. So now I will request our panelist, Dr. D. Parija, to take over from me.
So, distinguished colleagues, healthcare professionals, honored guests, we welcome you all to today's critical panel discussion on the role of infection control in our global fight against TB. So, despite significant medical advances, TB remains one of humanity's oldest and most persistent enemies. And what makes this particularly challenging is that TB transmission often occurs before diagnosis. So making infection control not just important, but absolutely crucial in our elimination strategy. Effective infection control isn't limited to protecting patients alone. It's about safeguarding healthcare workers and entire communities. Administrative measures, environmental controls, and the proper use of personal protective equipment work together to break the chain of transmission, as we know since quite some time now. And these practices are not only essential for controlling TB spread, but they also serve as models for combating other airborne infections. So we all need to remember that every prevented TB infection brings us one step closer to elimination. Effective infection control is not just a medical necessity, it's also a moral imperative. So our distinguished panelists, they bring decades of combined experience in TB elimination, hospital infection prevention, and public health policy. Through their insights, we hope to identify practical solutions and innovative approaches to strengthen infection control measures. So while we deliberate on our questions, I just have one request for my esteemed panelists. As per DG ICMR, he had very specific asks from the discussions. So he expected this panel and basically all panels to come out with answers to at least 3 questions. A, what are the successful innovations you think can be scaled up under programmatic conditions? I mean, flash in the pan innovations are easy, but are there innovations which can actually be scaled up under programmatic conditions? So it would be really helpful to everybody if you could speak about that while you speak about innovations. The second is, what are the current gaps that needs to be addressed through ongoing or planned innovations? Despite everything that is happening, are there still gaps that you think that innovators should look at more specifically? And third is, what are the key research priorities that the researchers should look at? So while we answer our questions, we would kindly request all of us to answer these questions from these 3 questions, answering these 3 questions, right? So that from this lens, that would help come out with a pretty objective output from this discussion for the government and for the program to take up. So I look forward to our conversation and actionable ideas that will emerge. So I'll start with So I'll start with Dr. Atul. So Dr. Atul Mohan Kochhar is the Chief Executive Officer at the National Accreditation Board for Hospitals and Healthcare Providers, Quality Council of India. So being the CEO of the National Accreditation Board, what, as per you, is the role of accreditation in building a culture of infection prevention, not only among the healthcare workforce, but also the community? And also while speaking, like mentioned before, would you like to pick up a few innovations that you have seen over your last few years as this that you think that should be considered for scale up, while also touching upon a few gaps that still need to be addressed through innovations? Over to you, sir.
So, good afternoon, all. Thank you so much for this opportunity. It's an immense pleasure for me to be here. So, I'm representing NABH. We are the National Accreditation Board, and we are into the 20th year of operations. And all our standards of accreditation, certification, and empanelment, they revolve around a linchpin of healthcare quality and patient safety. So today we feel very privileged that we partner with more than 23,000 hospitals in India, and we have sketchy presence though, but in 12 countries. So there are countries which follow Indian standards. So it's a real, I think, case for immense pride. So coming to the subject and the topic in particular, and your question in particular, Dr. Parija, thank you for asking that. Essentially, healthcare is a learned behavior, right? And airborne infections or any infection control practice requires dedicated habit building, because for any infection, not only the patients, not only the hospital acquired environment, but the hospital environment, but also the healthcare workers, the frontline warriors or the backline warriors also, they are all exposed to infections in a big way. So that's where the accreditation and the repeated culture of quality comes in very handy. I can unhesitatingly mention that during COVID, I mean, because that's been a watershed benchmark, what we have seen is, and what is on record also, that all hospitals which were accredited, they had less of morbidity and mortality. And only because there was changing SOPs from not only day to day, but rather minute to minute also. There were very frequently changes in how we should tackle, whether we should reuse the mask or whether we should. I mean, even the technique of hygiene went through a whole learning curve again and again. You know, those 6 steps or 7 steps, or how to do, or so. That's where accreditation, because one, the workforce gets used to following SOPs, and there is a culture and there's a system of training and retraining, which is very important. So that in particular is the USP of accreditation, besides other things. And hospital any accreditation framework, whether it is NABH or NQAS or JCI for that matter, hospital infection control or infection control is a key component there. And there are aspects which are of course covering airborne infection, but even if they are not covering, I mean the other, starting from waste disposal to hand hygiene, the basics, starting from the basics to the most advanced level of cutting edge technologies taking care of that, like CSSD is a part. Then I mean, just to give you one or two examples, even the very basic of how the wheels of a trolley wheeling a patient inside a OT should be addressed is also addressed in the infection protocols, right? So at that level of operations, speaking about scaling up uh, or promoting health care, those plan and non-plan innovations which could be scaled up. So many things come to mind, right? And just to give you an example, that during COVID, the CSIR funded project of uh, putting using UV rays as a very low cost innovation to sanitize the room, any room, whether it's a auditorium of this size and scale, or whether it's a operation theater much smaller in size, that found favor, and that is in use now, right? So all those, so that's just one thing, but there are many examples of day to day life which are absorbed from health environment, which can now be utilized even in in public life. And there are many SOPs, for example, where which the healthcare workers use or utilize in their day-to-day life, and which can be translated for the caregivers of a infected patient. So those we could discuss, but I will rest for now. But just my opening thoughts. Thank you.
Very pertinent points, and especially I like the thing that quality is a habit, right? The more you reinforce it, the more it is likely to stay put. And I was honestly not aware that we are there in 23 countries. It's indeed a matter of pride.
12 countries.
12 countries, yeah, it's
Yeah.
indeed a matter of pride. So absolutely. But next I would request Dr. Sanjeev Kumar Singh. He's the medical director from Amrita Institute. So, what are the relevant CDC and WHO guidelines around handling airborne infections? And are there any best practices in airborne infection prevention that you would want to talk a bit about, especially from a lens of programmatic scale up?
So, thank you so much, and really an honor and a privilege to be part of this. And this, congratulations to ICMR and all those who have been associated for organizing such a fantastic event. CDC, for handling airborne infection, they have set up a guidelines which is very, very well known and very well established. Basically, if we can sort of divide this into three: structure, process, and outcome. And structure here is the most important, because you need to have a negative pressure room when you're handling airborne. So basically, contact, droplet, and airborne, there's slight thinner line between droplet and airborne, but since you have to handle it, it is basically all the large droplet which crosses more than 3 feet falls into this category, and this needs to be sort of handled well. It could only be handled well with negative pressure. So the structure falls, that particular room is very, very important. It has to be a negative pressure, which is minus 2.5 Pascal, needs to be monitored, because the negative pressure you could build, but if it is not at 2.5, it doesn't basically take away the airborne and transmission. It needs to also have an entire room. Entire room also should have a wash and the waste bins. And there needs to be a door which separates the entire room with the actual room, plus a temperature of 21 to plus minus 3, a relative humidity of 40 to 60. One of the very, very key component is heating, ventilation, and air conditioning, where there needs to be a good supply and a return. But supply could be from 100% fresh air, and the return needs to be HEPA filtered, because it goes out into an environment. That's how negative pressures are. So those are very critical component, which is very important. And within this, it is also unidirectional flow would be another critical component which needs to be sort of taken care of. So when you're doing all of this, where you're maintaining temperature, relative humidity, or a pressure, and air changes, because it has to, the air for airborne cannot be static. So rest of the critical care units and droplet has 6 to 12 air changes. Here you have more than 12 air changes, so that the air doesn't remain static, and it needs to be sort of also monitored through the parameters. So the guidelines have been mostly from CDC, which also takes care from ASHRAE and American Institute of Architecture as per the design. Now, once the structure is done, the process is important, because there needs to be an adequate signage when you get in. There needs to be limited entry of people who get into an airborne, because hordes of people with series of professors and associate and assistant, and they cannot should not get in. There needs to be a good wash with the donning of the PPE, and as much as possible no touch in the airborne area, plus flow from clean to dirty. And then when they come out, again doff, and then sort of so process is important. As an outcome, you need to measure your hand hygiene practices, your biomedical waste management practices, and PPE donning and doffing practices. So you had asked 3 questions when you started. Can there be an innovation? So I'm not sure why we always have to, in a low middle income country, have to always adhere to CDC, American Institute of Architecture, and ASHRAE guideline. Can there be an innovation which is low cost, which could be, now everything is point of care. So if there could be a point of care device which has a technetium, silver, as well as HEPA filtration, so that it takes in, and that could be sort of immediately pumped down. So these point of care devices are available, and it will be low cost, rather than restructuring the whole negative pressure. So you have to have a supply, so a central supply and a fan filter unit and a return, and managing the recirculation, plus an HEPA. So it is decently close to 15 to 20 lakhs per room, where air velocity also is very, very important, because you have to have a decent size of 250 square feet of room to have that velocity within that. Can this be managed by a point of care device rather than restructuring the room? Because we are low middle income country, resource limited, may not be done. Dr. Atul mentioned about UV. we have used this UVC. We have seen the efficacy, we have seen the safety. We have used UVC in a biosafety cabinet, and we have seen the log reduction. It needs to be used more often as a good disinfectant mechanism, which could be mobile, both in the rooms as well as in the waiting area, because waiting area is one area which is sort of having untested tubercular patients, and there could be a lot of infections. Third is, can we go back to basics where natural ventilation is available and sunlight is available, because we have gone into a completely centralized air conditioning area following a Western philosophy and Western architecture. We need to go back and see, can there be a low cost, open air, natural, daylight ventilation which is available, which could be sort of helpful to prevent airborne infections.
Thank you, sir. That was really insightful. And before I joined JHPIEGO, I was in WHO. But before that, I did a small stint with FIND under the able guidance of Dr. Sarabjit, and I completely understand the effort that it took to just maintain and run a BSL-3 lab with the air handling units conking off, with the ducting, with the flooring, HEPA filters, and it is not easy. It is easier said than done, and I completely agree with you that it would be useful to have some low cost local innovations which are effective, which are safe. We are not compromising on safety and effectiveness, but yes, I mean, we should all look at it. Since we are joined by Dr. Upasana, she's the director of Yashoda Hospital, ma'am. So just to continue with sir's thing, what are the this is especially regarding the recent COVID pandemic, right? I mean, we all went through that couple of years. So what are the lessons from that pandemic that taught us on our preparedness, especially from an impact from airborne infection control? Because we all know that the next pandemic and the next pandemic are likely to be airborne, right? So same questions. Would you want to talk about any successful innovations? Also, ma'am, just one small addition to that. While we talk about air handling unit and negative pressure rooms, which are more suited for high exposure settings like a lab, what about wards, right? What are the measures you think that can be put into wards to ensure safety for not only the TB patient, but also the other patients in the hospital? Thank you, ma'am.
Thank you so much. And it's actually honor for me that I am sitting with all these stalwarts. But I can share our experience at the time of COVID. Luckily, my hospital got lots of awards because we could save many lives. And what we have done that time, there was a central AC unit, and there were one floor was different, every room was having different unit. So we have kept all the patient in that place so that unnecessary these air circulation should not harm others. But after that, and we have put this UV light. Blue Star is our company, AC company. So they have done something that they have put UV lights in their duct. So they claim that they have done a great job, and we also appreciate them for that. But after that, when we started making a new hospital, what we have done, we have kept everything like in that manner that one particular area should not talk to each other in form of air units, as well as if there is any pandemic, we are 100% ready for that. We made that building accordingly so that one area we can cordon off for infectious patient, as well as we can keep our healthy patients separately with them. That is why we have made this building as a total green hospital, platinum level LEED certified. So there is lots of lights are there, lots of green lights and cross ventilation of the all corridors. And as we are having a accreditation from last 15 years, so we are following all the norms. My infectious disease doctor is also sitting here. We are following this negative pressure in wards. Also, we have make rooms in wards. Sometimes it's an open TB patient is admitted, so we are admitting him in that place only, in that room only. So we are trying to create something where, because our hospital is a step center for TB, which is declared by union. So we need to take care of all these things because lots of TB patients are coming. So for that, we have made that building accordingly. So we are 100% ready for next pandemic, because that COVID has given everybody a lesson that we need to prepare our AC, our rooms, everywhere, that if something goes wrong, which I'm 100% sure after a few months you will listen that China is sending something else to us.
Thank you, ma'am. Very irrelevant points again. And yeah, I fingers crossed that China doesn't send something to us this quickly. So yeah. So now coming to Dr. Sarabjit, as I mentioned, I've already worked with Find earlier. He was my boss, so I kept the longest question for him. So, so Find has been a key partner to national programs, not only in India but across multiple countries, especially on culture DST labs and DRTP centers, right? So, from your experience, can you share some key lessons learned from your project on improving airborne infection control? Same, what are the biggest challenges? How were they overcome? How do you think we can better integrate infection control measures with other healthcare delivery, such as patient care, facility design, and occupational health? And do you still see gaps that you think need to be redressed?
Thank you, Dr. Parija. And I'll just give you, I'll take a minute to tell you about what this whole project is about. So, this project is actually supported by a global fund under the COVID-19 Resource Mobilization Grant. And this was to, help the drug resistant TB centers, which you are aware, these are tertiary care centers usually located in medical colleges or tertiary institutes. And where, the drug resistant TB patients starting from rifampicin resistance, MDR, or even, high level resistance like XDR cases get admitted and treated. So 100 such DRTB centers across the country were picked, and they were to be supported for complying with the AIC, or infection prevention and control. We did an initial assessment for these 100 sites, and then later, because the project was so successful, we added another 85 sites. So in all, we had 185 sites. The assessments were done, and they included the high-risk areas in these hospitals or institutes, the drug-resistant TB wards where the patients were admitted, the OPD areas, the radiology room, the bronchoscopy room, and then, if there are certain intervention areas, corridors. In general, practically all the high risk areas in a hospital were assessed for air changes per hour. What was the design structure, which Dr. Atul just mentioned, that there are certain guidelines by NABH, which the hospitals have to comply with, whether they were being complied with. What was the training status? What were the, how the healthcare workers were using the personal protective equipment, which is again a very critical component. And based on those, recommendations were being made. So we started with very simple things, and Dr. Parija, this is in line with what DGICMR mentioned, that how we can be more pragmatic in implementation under programmatic conditions, and these need to be low cost, high efficiency interventions. So the focus was on these low cost, high impact interventions like using natural ventilation, sunlights, then going to mechanical ventilation, and finally in some of the areas where it was not possible to have the natural ventilation or mechanical ventilation, we had the UVGI, the upper room ultraviolet C lamps, which need to be installed, because all these fixtures, the UVC fixtures, they come with a rider. Their maintenance needs to be taken care of, dusting needs to be done, lamps need to be changed. What you put today, the effectiveness will slowly wane off if a simple thing like dusting is not done of them. So based on that, we've kind of assessed, and currently we are in the process of installing these UVGIs. Another important intervention that we did was we created what was known as sample collection booths. These were like open, just with a roof, where patients could go, they could collect their sputum and then deposit it to the lab. And the second was a patient waiting area, which was a big innovation. These were like sheds, with roof, with seats, all open, so that they're protected from rain and sun, but then they don't have to wait in the corridors where the transmission becomes higher. And patients who come with drug sensitive TB or just with a normal chest infection go back with drug resistant TB. When I come to challenges based on this assessment, the key challenge was that even the hospital administrators, the deans, the medical superintendents were not aware of the airborne infection control guidelines. The second most important challenge was that there is a a hospital infection control committee which needs to be constituted, which looks after the infection prevention and control in the entire hospital. Most of the hospitals just had a tick in the box. There was a committee, there were members. Some of the members didn't even know that they were a part of this committee. Some committees had not met for several years. To make these committees functional, to have them own their responsibility and then take some actions was a big effort that this project did. And today, I'm proud to say that out of these 185 centers, 90% of these institutes now have a functional hospital infection control committee, which has met at least once in the last 3 to 6 months. Right. This is how we kind of turned the wheel, and now it is gaining momentum. The third important challenge was related to the healthcare worker training. Everyone had a thought that airborne infection control is something which is the responsibility of the medical superintendent or the infection control officer or someone higher up. We are not interested. Hamara kaam nahi hai. Training them, because like Dr. Atul mentioned very, vocally, that until and unless this becomes a habit, and everyone has a role to play, right from the class 4 workers right up to the medical superintendent, everyone has a role in infection control. This is not going to work. So training all level of healthcare staff and then also helping them understand the importance of personal protective equipment and how to use them effectively. Most of the people, they were using N95 respirators which were available, but the application was totally wrong. No fit test was done, no instructions, how to maintain them, whether to reuse them, when to throw them, when to replace them. All these things were not, the healthcare workers were not aware. The fourth important point was the patients and their family members themselves. India, we are a very culturally strong community. एक पेशेंट के साथ 4 फैमिली मेंबर्स आएंगे हॉस्पिटल में. If he's admitted, there may be even more, because everyone has to give their share of fruits and vegetables to this patient. Now, how do we make these patients and the family members aware on infection control guidelines? And that, until and unless they keep this segregation or isolation or 3 or 6 feet distance, and they can wait outside the hospital in these waiting areas rather than standing outside the OPD when they know that there are 20 people in front of them who the doctor would see, and then their number would come. Simple measures, online registration systems, token system, big boards, which flash the numbers and say, okay, now it's your turn, you go, would actually help help reduce the transmission. The fourth important challenge was the constraint of space. So even if you had good corridors, you had good, large windows, they were all kept closed for a simple reason. There were some boxes kept in front of the window, so it gets blocked. The doctor's room, the way, the table and the chairs were placed were totally against the airflow. Right. So the doctors were actually, the healthcare workers and the patients were both now at risk of getting the disease. Just changing the direction of the table, the sitting arrangement actually helped. These are no cost interventions. Then coming to how we have to integrate this with the what I call as multi-sectoral collaboration. Architecture has made such advances, and medical architecture is a discipline in itself. What we have seen is that even the tertiary institutes, till now, the construction is still conducted by the public works department in most of the places. And in most of these instances, there are no qualified medical architects, who can help design. So this needs to be leveraged. Or, architects should be trained, when they are designing a hospital or a health facility, on how to build in all the AIC compliant, structures. The way they design the structure should be AIC compliant. I know Malik is going to talk more about the AIC guidelines. Just wanted to give a reference that, and this is again, Dr. Sanjeev, you mentioned that why India has to follow the international guidelines. 2010, India had its first airborne infection control guideline, which was very, very contextual to the Indian settings. Very recently, we have revised that guideline again for use across the country. And this is not TB specific. This is airborne infection control guideline, because one of the worst transmissions is, through airborne. We saw it in COVID. There are so many other influenza happens almost every year. There's so many airborne infections which happen like this. So I will just kind of give three, points. One is increase awareness. Two, look at low cost interventions first. Three, UVGI is very important, very critical, because in places where there are extremes of temperature or climate, like, very hot and very cold, we will not be opening the windows. We'll not be opening the doors. We need air conditioners. Let's not close our eyes to that we will do away with air conditioners and we will have all windows open. It's not going to happen. UVGI plays a great role, but maintaining these UVGIs needs to be, again, it has to be a habit or a quality control. Otherwise, they are not effective.
True. Thank you, Dr. Sarabjit. And as you rightly said, especially in India, you can't have. There has to be some context-specific changes that will have to be made. We cannot simply forget that. So I'll finally come to Dr. Malik Parmar. He's the NPO DRTB and TB prevention with WHO India. So Dr. Malik, what have been the efforts and progress made in India on airborne infection control to date? And can you also share a few innovative ideas on reduction in the risk of airborne infection TB, not only at the hospital level, but also at the household and community level? And because we have you here, and you are the NPO of TB prevention as well, and prevention is not only AIC, but in TB prevention is itself a whole topic in itself, right? So since we have you here, would you also like to throw in some light around that? Thank you.
Thank you, Dr. Parija, and I really thank the organizers for having me here, and especially sitting in the midst of this esteemed panel. The questions are in two parts. I would keep it as two parts: what has happened so far, and what needs to be done, especially keeping the prevention element in mind. If I get your questions right, okay. So let's start with the first part, which is fairly easy. Dr. Sarabjit has made my life easy by touching on some of those points. So, I also go back to 2006, not even 9. 2006, I was a consultant, a medical consultant of WHO based out of Gujarat, and we were working on developing the first DRTB center in the country, drug-resistant TB center, at BJ Medical College, Pune, Ahmedabad. And there was excitement about, using UV lamps, etc. And they kind of locally procured it and installed it, and they asked us technical questions around it, and we had no clue about it. So we started referring to documents, etc. And one of our seniors linked us up to the experts in the United States at Boston University, who were, delving into the then UVGI guidance, etc. And we were trying to discuss this, and one fine day we just get a call that come fast in the ward, there is an accident that has happened. I said, what happened? So we, the pulmonologist of the ward, etc., we rushed to the place, and we were told that all patients and the providers were complaining of rashes on the skin and burning of the eyes, etc. So we immediately got this, that has anybody switched on the lamps? Said, yes, we did switch on the lamp. So it so happened that all the switches were in one line for all tube lights, fans, everything. And there was this style of one of the gentlemen out there to do this. So he just switched on all the lights, and the UV lamps were also lit. Although there were instructions that don't use them till the time, we had to go and remove that plug. I mean, remove the switch itself. And they were given clear instructions not to use them. Eventually, they were removed, because there were no specifications available at that time, no guidance whatsoever, and it did harm. Okay, so while trying to get into innovation, one also has to keep the safety, the efficacy component in mind while delving into these newer products. Of course, over a period of time, there have been new evidences and refinement in the technology as well to give us much safer and much more clearer guidance on how to install UPGI Live. But then at that time, Dr. Sarabjit, my colleague, was in the Central TB division, and the WHO came up with the TB infection control guidelines in 2009. And Dr. Sarabjit took up, under guidance of the DDG-TB then, Dr. Chauhan, let's remember him, right? And they started this effort to come up with the national guidelines, right? And a national set of experts, led by Dr. Jindal then from PGI Chandigarh. We had a mix of pulmonologists, clinicians, microbiologists, public health specialists, architects, engineers in that group, if I correctly remember. And they started looking at the WHO guidelines, and every time they would read a section, or the first question would come, is this possible in India? Can this be implemented in a medical college or a primary healthcare center in India? And everybody unanimously said, no, this is very difficult. Still, at that time, we then also, I moved into the Central TB division in 2010 and was handed over that portfolio of airborne infection control. So 2 such consultations were kind of, organized by Dr. Sarabjit at that time. And the third one came to my, role. And in the third meeting, it was finally decided that, okay, let's make this context specific to Indian situations. And at that time, we had a CDC team. We had Dr. Puneet Diwan, who was leading us in WHO at that time, who contacted us with the CDC Atlanta team, who was working on respiratory infection control and prevention guidance for healthcare workers. So we got those materials, we amalgamated that into the WHO policies and came up with the National Airborne Infection Control Guidelines, which was a mix of these two. It was not a direct adaptation of what WHO was recommending, but keeping it context specific. And the recommendation that came out was, listen, let's not rush into implementation of these guidelines. We ourselves are not very clear on how this will be implementable or not, what resources it will entail and require. Let's do a pilot. So about 3 states volunteered, and 35 health facilities ranging from primary healthcare facilities to tertiary care institutes, including 2 private hospitals, were included. And various departments, what Dr. Sarabjit was mentioning in the current project, all those departments were also kind of, identified where the risk of infection transmission, particularly for TB, was high based on the prevailing evidence at that point in time. So we did this a year. And then the Airborne Infection Control Guideline also had a monitoring mechanism of quarterly reporting. So those 35 facilities, same things which you heard from Dr. Sarabjit, establishing an infection control committee and getting all the trainings done and having administrative, environmental, and protective measures. A round of assessments was done by experts where the ACPH, etc. were done. Reports were given and follow-ups were done. And after a year, when reports were kind of, called for, we saw that progress was only made on administrative front, administrative interventions, I would say, where rules and regulations were changed a bit, where there was no cost involved. But environmental aspects and other things where money was involved did not go forward. But there was a 50% change that we saw even then, only with administrative factors. Then so then the government of India decided that, okay, listen, this experience tells us that this is too resource intensive. TB program alone cannot handle such a huge initiative. So let's prioritize. So prioritization was done for labs, culture DST labs, for drug resistant TB centers. And then eventually in 2013, the HIV program took it up for the ART centers. So that's how, these were included in the training curriculum of all these specific staff who were managing these. And then we had, few innovations and interventions by the states, like some tried out corners. where there would be, a place where the people who would be entering into the facility would be kind of counseled, given fast tracking systems, etc., masks and spittoons, etc. And those were tried out, and some research were also conducted around that. Some states came up with AIC kits to be given to the patients, so that they can take home, which would have a spittoon, 5% phenol, etc., for them to kind of do this. But then eventually, it remained in these patchy areas as implementation. Then came COVID, and we heard just now on what COVID taught us. And going to the next part of the question, it also kind of had a lot of public health kind of interventions in terms of masking, distance. Remember the do gaj ki duri elements, but these were not behavioral changes. These were enforced. There was police behind enforcing this, if you recall, right? But this is what is required in terms of the change in the behavior that is being spoken about going forward. But let's look at how do we innovate in our thinking. If we keep doing this, we now have the revised guidelines based on the recent evidence-based WHO guidelines and the experience of the 185 centers that have been assessed under the project. New guidelines are going to be out. Would this undergo the same things? Where will the resources come from? Who will take the ownership of this? So now globally, along with the AMR IPC program, there is now a recommendation, a global action plan is being worked up for IPC, and a national action plan is also expected from all the countries. And there is discussion on having a national AIC program developed in India, which would then probably be an airborne component would fall under that particular structure, I would say, which would then have the necessary resources, funding, etc., to take it up systematically. And this will also be useful, for integration with NABH, for instance, right? The guidelines are evidence-based. Okay, so they can be integrated. We have multiple stakeholders. The NHSRC would have its role to play in capacity building, etc. There will be role of the NCDC. There will be role of the Kakal project, for instance. So all these stakeholders will have to lift and do their bit in taking this forward. In terms of preventing infection at the community level, some part of these basic principles like cough etiquette, etc., the kits, etc., can be taken to the community level, but that will require behavioral change. But if we have to think of source control, as one single point, source control. Historically, John Snow has shown us in the epidemic of cholera in London that you kind of identify where the source is and control that, it will take care of it. Where are the sources for TB? 27 lakh new sources of TB are occurring every year in India, incident TB cases, right? Finding them and treating them is one important thing. But where do they come from? Next year, another 27 lakh. The next year, again, 27 lakh. So can we go one step ahead in our thinking and innovate to kind of, have those who are infected identified and stamp the spark before they turn into active TB cases and reduce the sources of infection, the potential next year sources of infection through policies like TPC, TPT, while we are waiting for an effective vaccine to come around the corner. This is something which I would like to pitch as an important innovation. I'll stop here, Parija. Thank you.
Thank you, Dr. Malik. Thank you, all panelists. We are way over time, but to be fair, we also started late. So thank you all. Thank you. We'll end it at this.
So thank you, Dr. Parija, and thank you, our esteemed panelists. So now I would request Dr. Parija to please present the memento as a token of thanks to our eminent panelists. Thank you. Yes, thank you. Thank you very much. So we have